Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a digital partner for this event, and the focus of today's session is medical documentation. And now it is my privilege to welcome Dr. Meenakshi Sundaram Sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiology and has held key positions including governing council member, president and state secretary of ISA Tamil Nadu state branch. So now without further any delay sir, over to you. Thank you.
Uh, Thank you, Rempa, Clarinet, for the opening remarks. Now it is my pleasure to welcome the delegates, faculty from Bangalore Medical College and Research Institute. In this second episode of Puthukkottai Bhudhan, the most number of participation is from Bangalore Medical College and Research Institute, Bangalore. So I thank the faculty very much. They are more interested. The last webinar under the series Puthukkottai Bhudhan, that is 49th, was held in the last week, that is 24 12 2025, before Christmas. And at this time, this 31st, it is before New Year. So at the outset, I wish all of you a happy New Year, happy 2026. And God should bless you all with the affection and the likes you have. It should be fulfilled. So extend my best wishes. Uh, Today, the last time the topic was CPCR guidelines, recent guidelines. So it was participated by Dr. Abhinaya, postgraduate from Pondicherry, and Dr. Baljit Singh from New Delhi, and Dr. Rakesh Garg from New Delhi, which was moderated by Dr. Chakra Rao, Kakinada, Andhra Pradesh. 873 people attended the session. And today, in this documentation webinar, the youngest faculty is Dr. Madhu Shravani. Madhu Shravani is a third year resident in Bangalore Medical College and Research Institute. And she has done her undergraduation from Viswabharati Medical College, Karnool. So she is from Andhra Pradesh basically, and she is interested in regional anesthesia and critical care medicine. And her extracurricular activities will be dance and music. So dancing is, she is not a professional dancer, but she will dance to anybody's tunes, and she will make others also to dance to her tunes. So why I am saying this, she is a eligible bachelor. That's what I want to say, because minimum 900 people will be watching this episode, and I want to inform everyone. Dr. Madhu, as per the name, she is a sweet lady doctor in anesthesiology, and she is yet to be married. So I wish her all the very best. And it will be followed by, she's going to talk about clinical decision support systems. So she needs a support also in future, which she will get a sure. So, but Dr. Asha is assistant professor in Bangalore Medical College, and she has served as a EC member of ISA Metro branch, and she was the faculty at the Airway Workshop Conference, KISACON 2024, and she's a scientific member of that Karnataka Conference 2024, and she was chairing and presenting lectures in state conferences. Her areas of interest will be difficult airway, and she is interested in painting and trekking. So to maintain her fitness, I think she is interested in trekking. So I don't know how she is trekking with this time. How it is possible for a lady to trek means the woman power is phenomenal. So she is doing trekking means that is a tremendous performance, and she is going to talk on electronic health records today. And it will be followed by Dr. Naziya Banu, the ever smiling lady doctor from Karnataka. She is also an assistant professor from Bangalore Medical College and Research Institute, and she has presented a paper in ISACON 2021. And she's organizing faculty in the regional anesthesia workshop, which was conducted in collaboration with anatomy department. And the areas of interest will be regional anesthesia and pediatric anesthesia. So we can say she's interested in pediatric anesthesia as well as pediatric regional anesthesia. And she's interested in singing and listening to the music. Now you see, she's a good singer and Madhu is a dancer. So I don't know who is going to sing and who is going to dance. So I expect some extracurricular activity at the end of the webinar. And to moderate these three ladies, we call it as three goddess Lakshmi, Saraswati, Parvati. So these three people are there. So we wanted to moderate these people. So we have catch hold of the professor of the Bangalore Medical College and Research Institute, Dr. Dayananda. Dr. Dayananda is a professor and she's a speaker in ISACON 2006 National Conference. She has he has chaired the session in ISACON 2021 and Karnataka State Conference also. His areas of interest is pediatric anesthesia. So Dr. Naziya is following his steps only, pediatric anesthesia and obstetric anesthesia and critical care. So it is quite nice to see the maternal and child health program. He is interested in obstetric and pediatric anesthesia, and he is interested in reading literary books. So I want to repeat, he is interested in reading literary books and not anesthesia books. And he is interested in walking because he has already covered all anesthesia books. So he is walking relaxedly, reading literary books, and I wish him all the very best. Now I request the faculty to start delivering their lectures. At the outset, I request Dr. Madhu to deliver a lecture on clinical decision support systems.
Thank you very much, sir. Good evening, everyone. Thank you for all my faculty for giving me this opportunity.
Recording in progress.
Today, my topic is clinical decision support system. We'll be dealing with this topic under following headings. Coming to definition, clinical decision support systems are interactive computer programs which are designed to assist health professionals with decision-making tasks. The basic components of CDSS include dynamic knowledge base and inference based mechanism, and implemented through medical logistic modules. It provides patient-specific information, uses evidence-based knowledge, assists clinical decision-making, and it assists and doesn't replace the clinical judgment. Coming to the history, it started in early beginnings like 1950s and it progressed till now 2010s with AI and mobile health and telemedicine. Anesthesia and emergency care involves high-stakes, team-based decision-making under time pressure. Decision-making includes information gathering, integration, hypothesis generation, and treatment selection. Diagnostic errors are major cause of adverse events in such settings. So the CDSs have been shown to improve decision-making efficiency and effectiveness. Most existing CDSs focus on final treatment decisions, neglecting the early cognitive steps of decision making. So effective CDSs should support hypothesis generation, data integration, and consideration of alternatives. Early decision making requires shared situational understanding among team members. This shared understanding is achieved through conversational grounding within the teams. CDSS uses alter team structure, communication, and diagnostic processes with important implications for future CDSS designing. This is the flowchart depicting clinical decision support system. It is a driven tool to assist healthcare professionals in clinical decision making, which allows timely access to best information, guidance-based clinical evidence, smart clinical assistance, better outcomes for patient recovery, and trust and consistency. This is the picture depicting when we'll take the patient lab values, history and physical examination, and electronic medical recording will be done. And based on patient monitors, the input will be given to the CDSS system. And finally, the output will be given to the clinician, which helps in taking the decision. Why CDSS is needed in anesthesia? Because of information overload, vitals, lab values, drugs, time pressure, we have to react at the earliest. human limitations like fatigue, cognitive bias, memory errors, need for standardization and safety. Unique challenges in anesthesia like rapid physiological changes, narrow therapeutic drug margins, polypharmacy, high medical legal risk, cognitive overload during the crisis. Our role of CDSS it acts like second cognitive safety net, reduces omission and commission errors, support guideline based practice. Core components include the data inputs which we have to give to the system like age, weight, BMI, ASA status, comorbidities, real-time vitals of the patient, ABG, electrolytes, hemoglobin, drug administration data, and ventilator parameters. Knowledge base include like anesthesia guidelines, standard protocols, drug databases, evidence-based algorithms. Inference engine including like rule-based, predictive analysis, trend analysis, output interface like alerts, reminders, dosing calculators, and risk scores. This is the picture depicting without CDSS and with CDSS. Without CDSS, early on, the anesthesiologist will note the parameters which are altered in the monitors, and then senior physician will take the help. And this is a like little a late process where we try to understand the condition. With the help of CDSS, it is like team structure, communication, anesthesiologist and CDSS team also helps to put all parameters in one place so that we can take the decision at the earliest. So it account customizability, addressing ethical and legal concerns, user-centered design, collaboration, integrated with electronic health records, continuous updates and knowledge expansion, evaluation and feedback mechanisms, and it is transparent and explainable artificial intelligence, continuous improvement, and interoperability and standardization. Now, CDSS in anesthesia, how it helps, like alert system, suppose if any hypotension, hypoxia, drug allergies, dose calculator, weight-based or renal hepatic adjustments, diagnostic support, differential diagnosis suggestions, cognitive aids like crisis checklist, especially if malignant hypothermia or anaphylaxis where we had to react at the earliest, protocol, enhanced recovery after surgery, sepsis bundles. Rule based, if example, if mean arterial pressure less than 65 for more than 3 minutes, hypotension and alert. If potassium more than 5.5, hyperkalemia protocol should be followed. Predictive CDSS includes predict hypotension after induction, predicts postoperative respiratory depression, ICU admission prediction. This is a picture showing the screen of the CDSS where we'll give all the inputs to the system based on our patient parameters, and behind shows the monitors. So all patient vitals and parameters will be shown in one screen so that we can depict the underlying condition at the earliest. Suppose if we take an example of malignant hypothermia, the rise in ETCO2, tachycardia, those all will be seen at one place so that the CDSS supports us to take the decision at the earliest. This picture left side shows with CDSS and right side shows only the monitors without any CDSS system. Coming to preoperative implications, pre-anesthetic evaluation, ASA classification support, stop bank score calculation, cardiac risk stratification, pulmonary risk assessment, drug-related support like anticoagulant stoppage alerts for neuraxial safety, beta blocker continuation reminders, ACE and ARB holding alerts. Optimization alerts like anemia detection, electrolyte abnormalities, and poor glycemic control. Perioperative stratification, AI, it is like an AI only. So this helps for ASA physical status stratification to detect postoperative delirium with preoperative risk factors, prediction of difficult airway by using facial pictures, checking the completeness of preoperative checklist, suggesting the appropriate preoperative antibiotic, telemedicine in preoperative period like preoperative patient education, smoking cessation, and initiating respiratory exercise. Coming to intraoperative implications, like hypertension alerts, hypertension alarms, MAP declining warnings, ventilation support like hypoventilation detection, high airway pressure alerts, ETCO2 trend analysis. This is a picture showing the above picture shows the entire parameters in a normal range. Like all the green color indicates the patient is adequately doing during the ventilation, and below picture shows the red one indicates the patient is having hypotension, heart rate is low. So by this parameters which are depicting at one place in one screen will help to intervene at the earliest. These are the alarms which are used to define react at the earliest. Drug dosing and safety, weight-based drug calculators, neuromuscular blocking dosing, TOF guided reversal suggestions, allergy and interaction alerts, Crisis management like anaphylaxis protocols, malignant hypothermia alerts, massive hemorrhage protocol activation. In regional anesthesia, anticoagulation safety checks, timing alerts for neuraxial blocks, local anesthetic dose calculators, and local anesthetic systemic toxicity alert. This is the picture depicting a malignant hypothermia without any CDSS team expert. This is the picture depicting CDSS team expert when malignant, example, a scenario like malignant hypothermia. You can see all parameters at one place, like rising CO2 tachycardia, all the parameters which helps in coming to conclusion at the earliest. ABG parameters also, the rising CO2 levels and all. So all will be in one place for helping us. Postoperative implications like post-anesthesia care unit monitoring, respiratory depression alerts, hypoxia prediction, delayed emergence warnings. Pain management, opioid dosing safety, multimodal analgesia prompts, renal or hepatic dose adjustments. ICU decision support, early warning scores, sepsis detection, ventilator waiting support. Coming to advantages, it reduces the medication errors, improves guidance adherence, enhances team communication, supports junior anesthesiologists, improves the patient safety. Patient safety like reduced medication errors, early complication detection. So this is a very precise caring with patient-centered care, reduced medical errors, enhanced decision making, cost saving, increased efficiency, enhanced patient safety, compliance guidelines and regulators, adaptive approaches, resource optimization, interoperability and data sharing, and network collaboration. So global knowledge and access and gaining foresight. So the quality of care, protocol adherence, standardization across the providers. Cognitive support reduces the workloading during crisis and supports the trainees. Coming to the limitations, alert fatigue, over-reliance on technology, poorly designed interfaces cannot replace the clinical judgment. We have to give the accurate data input. And suppose if any software malfunction, we need to have backup for our own decision making and intervening. And power supply related issues also can be there. So anesthesiologists are experience-based, context adaptive, and patient-specific. CDSS is a consistent, data-driven, and protocol-based. Coming to ethical and medical legal issues, CDSS is advisory; it is not prescriptive. Judicial accountability, it remains. Finally, is decision maker is a clinician. Override must be documented, and data privacy is essential. Coming to conclusion, CDSS is decision support, not a decision maker, so it improves the safety and consistency. Effective use requires training, clinical insight, and proper system designing is necessary. These are my references. Thank you.
Good evening to all. Able to hear me? Hello?
Yes, sir.
Yes,
Hello?
sir. Yes, sir.
Yeah. Good evening to all. Sorry to some problem with my mobile. So, yeah. Sir, shall we continue with the next this thing or we'll have
Yes.
some...
Yes,
Yeah.
sir. Yes,
Okay.
sir.
Yes, sir. Okay, sir. Dr. Who will do it? Asha, you will do it or our...
Yes, sir. I'll be doing now, sir. I'll be doing
Okay,
now,
okay,
sir.
madam. Okay, madam. You can start, madam.
Okay, sir. Am I audible, sir?
Yeah, you are audible, Asha.
Yes, sir. Yes, sir.
Yes, madam, you can able.
Yes, sir. Good evening, everyone. My warm welcome and all. My heartfelt thanks to Dr. Meena for giving this opportunity today. I'll be talking about electronic health record. I'm Dr. Asha N from Bangalore Medical College and Institute. My objectives for today's session will be defining electronic health records and their role in anesthesia. We'll be understanding Indian guidelines and policies. We'll discuss about advantages and disadvantages, identify ethical and legal issues, and we'll apply our best practices. As we know, electronic health record is a digital version of patient medical record. It is used to store, manage, and retrieve health information. It has replaced traditional paper based records and it is accessible only to authorized users. Here we come across two terms, EMR and EHR. EMR is electronic medical record. It is a single facility record, whereas electronic health record, it is interoperable across systems. What is an EHR? It is a digital record of patient health information, which includes medical history, diagnosis, medications, lab imaging results. What are the clinical and operational benefits of electronic health records? Electronic health records reduce cost and improve care quality. It enables accurate, legible, and retrievable records. It improves data mobility across departments. It supports coordinated perioperative workflows, particularly valuable for anesthesia services with high data volume. Coming to EHR adoption and system reliability, EHR adoption improves safety, efficiency, and care coordination. Success depends on both technical and human factors. Reliability requires data completeness, system resilience, high availability, and strong security. What do clinicians prefer? Majority of clinicians prefer EHRs over paper records. What are the benefits we get out of this? We save the time, information, and better report generation. These are associated with improved service quality. When we come to history of electronic health record, from 1960 to 1980, it was an early computer era. And early computer-based records were seen in larger hospitals like Mayo Clinic, but it was of limited use, mainly billing and local documentation was seen. In 1990 came the term electronic health record, which introduced system improved but lacked standardization and interoperability. In 2000, there was a huge backup from government and there was many policies were given. Incentives accelerated EHR implementation. Focus was given on quality and patient safety. From 2010 till present, there is widespread EHR use. E-prescriptions, patient portals, data sharing. There is emphasis on interoperability, mobile access, AI, and cybersecurity. EHS have evolved from isolated digital records to interoperable policy-driven systems supporting clinical decision making. What are the benefits of EHR? It has improved patient safety, it has reduced medical errors, it has faster access to patient data, it has better coordination of care, and it saves time and space. What challenges do we see? It is highly costly, privacy and security concerns, technical issues, training required for the staff, and increased screen time for doctors. When it comes for patient care, it supports clinical decision making, it improves communication among healthcare providers, enables telemedicine and remote care, helps in disease tracking and research. What do future hold in EHR? It is integrated with artificial intelligence. Intensive specialty. It needs to be highly accurate and it needs to be continuous, and we have to look upon patient safety. Components of EHR in anesthesia. We have to know about patient demographics, pre-anesthetic evaluation and ESS status, intraoperative anesthesia record, drug administration and fluid balance, automated vital signs, post-operative notes and pain scores. Role of EHR in pre-operative phase, we get access to previous anesthesia records, identification of comorbidities and risk stratification, allergy and medication alerts, improved documentation of consent. In intraoperative phase, we get automatic capture of vitals and timings, timestamp drug documentation, clinical decision support alerts, reduced transcription errors. In post-operative phase, post-anesthesia care unit and ICU handover documentation, pain management records, tracking of post-operative complications, and continuity of perioperative care. As an anesthetist, what are the advantages of this EHR? We get improved legibility and accuracy, improved patient safety, enables real-time data and trend analysis, easy retrieval for audit, supports research and quality improvement, medico-legal protection. Additional advantages are standardization of records, reduced paperwork in the long term, Data availability for teaching and postgraduate training supports quality improvement initiatives. Disadvantages, it is costly. Technical failures we get to see, reduce patient interaction, privacy and security risk, increased screen time and risk of inaccurate data entry. Now coming why EHR matters for India. India has fragmented healthcare with poor continuity of care. Patients move across multiple providers with no shared records. Emergency and perioperative decisions often made without prior data. So EHR enables us to continuity of care, faster, safer clinical decisions, reduced duplication of tests, population health tracking, because they are essential healthcare infrastructure, they're just not IT upgrades. Ayushman Bharat Digital Mission, the backbone of our India. National Digital Health Ecosystem by Government of India. It is a core building block. Our core building blocks are ABHA, which has unique patient identifier, and health information exchange, which provide provider and facility registries, personal health records, which enables secure consent-based data sharing nationwide. Clinical relevance, we get longitudinal patient records, inter-hospital data access, critical for emergencies and perioperative care. Why do we need national EHR standards? This was issued by Ministry of Health and Family Welfare. First, it was notified in 2013, and later in December 2016, it was once again revised. It was voluntary but nationally recommended. Why they exist? To standardize clinical data, to ensure interoperability across systems, to improve data quality, privacy, and security. They are aligned with HL7, FHIR, SNOMED CT, and DICOM. Coming to data ownership, consent, and patient right, healthcare providers create records. Patient own their health data. So explicit consent is required for data sharing and secondary use. Secondary use for research and analytics. ABDM uses consent managers. DPA architecture. Clinical implication, consent is auditable. But documentation has direct legal consequences. And ground reality, adoption challenges in India, system level, there is uneven digitization across states and hospitals, limited interoperability despite standards in hospital level, infrastructure and cost barriers, training and workflow disruption, human factors, increased screen time, alert fatigue, resistance to change. Bottom line, strong policy vision, on ground execution is uneven. India's EHR journey, APTM provides national digital framework. EHR standards ensure structure and interoperability. Ethical and legal safeguards are still evolving. Adoption is increasing. It requires standard enforcement, still data security. India's EHR success depends as much on people process as on technology. When to anesthesia in context, anesthesia is data intensive and time critical. APDM enables access to prior anesthesia records, comorbidities, allergies, medication via ABHA, better perioperative risk assessment, OT relevant EHR data, pre-anesthetic evaluation and ESA status, automated vital sign capture, drug administration and timestamps, PSEO handover and pain scores. How does it benefit for anesthesiologist? Improves patient safety, reduce documentation errors, better medico-legal protection, data for audit, research, and training. Clinical takeaway, ABDM-linked EHRs can transform perioperative safety in India if implemented correctly. Coming to ethical and privacy issues, patient confidentiality, data privacy and security risk, unauthorized access, informed consent for data use, concerns regarding ABHA linkage without clear safeguards. Legal rights and security. Patients have right to access medical records. Courts recognize EHR as legal evidence. Role-based access and audit trials are essential. Cybersecurity breaches carry institutional liability. So best practice for anesthesia team is need for accurate continuous documentation, proper onboarding and EHR training, structured data entry over free text, routine privacy checks and audit logs, cross-verification with clinical decisions. What are risks? Legal liability due to alert fatigue, system errors, and inappropriate use. copy-paste errors leading to incorrect documentation, citizens consent, and second use. Potential impact on clinician involvement in patient care. Applications of EHRs. Metadata. Metadata is data about the data. It provides insight into record authenticity and clinician involvement. Courts have used EHR data as legal evidence, sometimes compelling release despite hospital objections. EHR can both protect and expose clinicians legally. Data accuracy and integrity issues. Auto population can introduce incorrect data. Copy paste may propagate outdated or wrong information. Pre-filled templates may not reflect actual clinical events. Errors appear credible because they are time-stamped, system-generated, they are legible and detailed. What are the legal risks? Courts may treat inaccurate data as factual evidence. When it comes to copy, paste, and clone documentation, reuse of old notes can include irrelevant or incorrect findings. They may fail to reflect current patient condition. It creates inconsistency between narrative notes, vital sign, and medication timing. Legally, we seen as negligent documentation or misrepresentation. Alert fatigue and missed warnings. Excessive alerts reduce clinician responsiveness. Important warnings may be ignored or overridden. Examples: drug interaction alerts, allergy warnings. Legally, failure to act on these alerts may be interpreted as deviation from standard of care. Metadata and audit trails. EHR stored as entries were made or modified, late entries, if at all is done, or any corrections are done in between. Metadata can reveal delayed documentation, post-event charting. Legally, it can be used to question credibility, honesty, or intent. When it comes to privacy and confidentiality breaches, unauthorized access by staff, accidental disclosure of patient data, data sharing across systems increases vulnerability. Legally, violations of privacy laws, institutional liability for data breaches, and loss of patient trust. Over reliance on automation. Clinicians may rely on default settings, auto calculated dosages, decision support suggestions. Automation bias may override clinical judgment. Legally, clinicians remain legally responsible even if system contributed to error. Litigation and discoverability. Courts can compel full EHR disclosure, which includes deleted notes, audit trials, internal communication. Even system-generated errors can be used in court. Legally, EHR become a detailed forensic record used against clinicians and hospitals. How to mitigate this risk? Avoid copy-paste without verification. Review auto-populated data carefully. Respond meaningfully to alerts. Document clinical reasoning clearly. Maintain privacy and access controls. Educate clinicians on medico-legal implication of EHR use. Anesthesia EHR modules, evidence from literature, dedicated anesthesia modules improve documentation accuracy, support intraoperative data capture and workflow efficiency. It facilitates coordination between anesthesiologist and OT staff. Agile module is the agile development module. It allows interactive clinical feedback. Validation studies show improved usability and data completeness. Institutional policies for medico-legal risk management, clinical documentation, standards legal request, identify EHR super users for audits and legal review, maintain access to audit trials when required. It aligns EHR output with institutional ethical and regulatory considerations in EHR selection. Anesthesiologists should participate in EHR selection decisions. System must support anesthesia-specific workflows. Large centers use comprehensive EHR platforms. Smaller center may adopt modular or scale systems. Cost and implementation still affect the time system choice. The future challenges: artificial intelligence, interoperability, and cybersecurity. Increasing device connectivity is a cybersecurity risk. Anesthesia workflows are vulnerable to system failures. Ransomware is a significant threat to healthcare. How to mitigate this in training institutions analysis, and IT monitoring. AI offers of workflow and safe benefit. To summarize, these are in safety, efficiency, and quality in anesthesia, ethical and privacy risk, and robust governance. Indian digital health ecosystem is rapidly evolving. Challenges remain but are manageable. Anesthesiologists play a key role in safe adoption. India should clinical expert.
Hello. Hello. ನಿಮ್ಮ ಕ್ಲೈಂಟ್ ಏನಿದೆ ಏನಾಯ್ತು Can you able to hear me?
Yes, sir, you are audible.
Okay. Okay. Now, Dr. Naziya, are you going to start?
Yes, sir.
Okay. Okay.
Okay, sir. Yes, sir.
Hello, sir.
Oh, no, nothing, Asha. Okay.
Yes, sir. Yes.
I told
Thank you.
Naziya to start.
Yes, sir. Thank you.
Good evening, everyone. I thank Meenakshi Sundaram sir for giving me an opportunity, and I thank Dr. Dayanand sir for agreeing to chair the session. Today's topic is telemedicine in anesthesiology. So, WHO definition. Hello, Rimpa. Am I audible, sir? Hello.
Yeah, Naziya. Now it is audible.
Okay, sir. Yes, sir. My today's topic is telemedicine. The WHO definition of telemedicine is the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and for continuing education of healthcare providers, all in the interest of advancing the health of individuals and their communities. Telehealth. Telehealth is the delivery of health-related services and information via telecommunication technologies. Telehealth could be as simple as two health professionals discussing a case over a telephone, or as sophisticated as doing robotic surgery between facilities at different ends of the globe. So we start with the history. Telemedicine has evolved from early telephone consultations in 20th century to sophisticated digital platforms, significantly transforming healthcare. In 1900s, the concept of telemedicine began with transmission of heart rhythms over the telephone in Netherlands. This marked the first step towards the remote medical consultation. In 1920s, the use of radio for medical consultations emerged allowing healthcare providers to communicate over distances. In 1940s, radiographic images were transmitted between cities in Pennsylvania, showcasing the potential for remote diagnosis. In 1990s, the establishment of American Telemedicine Association promoted telemedicine practices and standards. The introduction of internet further revolutionized telemedicine, enabling more efficient communication and data transfer. Telemedicine services expanded significantly with various healthcare organizations adopting telehealth solutions to improve patient access and reduce the costs. The Veteran Affairs Systems became a leader in telemedicine, providing millions of consultations to veterans. So the recent development during COVID-19 pandemic. The pandemic accelerated the adoption of telemedicine as healthcare providers sought to minimize in-person visits. This led to surge in telehealth services with many patients and providers embracing virtual care. Telemedicine was rapidly adopted on a wide scale to minimize the direct patient interaction, which reduced the spread of COVID-19 virus. Its continued role for immunocompromised, physically disabled, patients with neurodegenerative diseases, wheelchair dependent, and those who have low risk for opioid abuse or misuse are good examples for intermittent telemedicine office visits. What is the need for telemedicine? Emergency medical care is designed to overcome the factors most commonly implicated in preventable mortality, such as delays in seeking care, access to health facility, and provision of adequate care at the facility. Need for telemedicine in India. India has a huge population with inequitable distribution of resources. 70% of India's population lives in rural areas, whereas 75% qualified consultants practice in urban centers. Vast land area with difficult, inaccessible terrain. Seasonal isolation of some tracts of land due to floods and snow, etc. These are the types of telemedicine technologies. There are two types: store and forward, and two-way interactive television. In detailed version, we have real-time or synchronous telemedicine technique, which is as simple as telephone call or as complex as robotic surgery. It requires presence of both the parties at the same time and a communication link that allows real-time interaction. Video conferencing equipment is the commonest technology which is used here. Peripheral devices such as teleotoscope, telestethoscope allows consulting remote physician to examine the patient. The second variety is store and forward telemedicine, which is also called as asynchronous telemedicine, acquiring medical data like medical images, biosignals, etc., and then transmitting these data to a doctor or medical specialist at a convenient time for assessment offline. Dermatology, radiology, and pathology are common specialties conducive to asynchronous telemedicine. It is most beneficial for population living in isolated communities and remote regions. Images of pathology slides, digital images of skin conditions shared from one location to another for diagnostic consultations. So how the telemedicine has evolved. Initially, it was point to point system. One patient end connected to one specialist doctor within the hospital. Then it progressed to multi-point system. One patient end at a time connected to any of the specialist doctors within the hospital. Multi-point to multi-point system, several patients and simultaneously connected to different doctors and at different hospitals at different geographical location. This picture will tell us how the information is transmitted from one district hospital to a specialty hospital, and they will get the inputs from them. So what are the advantages of telemedicine system? It gives us easy access to remote areas. Using telemedicine and peripheral health setups can significantly reduce the time and costs of patient transportation. Monitoring home care and ambulatory monitoring. It improves communications between health providers separated by distance. Critical care monitoring where it is not possible to transfer the patient. There is a continuing medical education and clinical research with the help of telemedicine, a tool for public awareness. It is a tool for disaster management. It acts as a second opinion and complex interpretation. It helps. It brings expertise to medical practices. Tele-mentored procedures, surgery using hand robots. Robotic surgery can be performed with the help of telemedicine. Disease surveillance and program tracking. It provides an opportunity for standardization and equity in provision of healthcare, both within individual countries and across regions and continents. So these are the major uses. So teleconsultation, telediagnosis, and teletreatment. The patient with the local doctor, he consults a specialist and obtains the line of treatment. There is tele-education and tele-training for continuing the medical education and training for doctors and paramedics from higher level of hospital or institution. We are also using telemedicine technology for this class. Telemonitoring, regular monitoring for intensive care and emergency care, support during disaster management. So what are the barriers in telemedicine? Perspective of medical practitioner, it matters. Doctors are not fully convinced and familiar with e-medicine still. It needs to be updated. Patients' fear and unfamiliarity. There is a lack of confidence in patients about the outcome of e-medicine. Financial unavailability. The technology and communication costs being too high sometimes make telemedicine financially unfeasible. Lack of basic communities in India also acts as a barrier to telehealth. So what are the infrastructure which is basic for telemedicine? We should have a hardware, we should have a software and a connectivity. Hardware, which includes telemedicine platform, clinical devices, video conferencing unit and communication hardware. Software, which includes operating system, licensed telemedicine software with an appropriate user interface. Example, Sanjeevani software in India. Connectivity options for telemedicine services are VSAT, which is very small aperture telephone network, PSTN, public services telephone network, ISDN, which is integrated services digital network leased in line. So this is the picture showing VSAT connectivity, PSTN for data transfer, and ISDN working. So now we come to application of telemedicine in anesthesia, how it is useful for us. So it starts with pre-admission anesthesia consultation. So this method was employed in Canada, where most of the population lives in a remote location. So they did a pilot study where for which informed consent is required, which is separate from the process for consent for treatment. They are informed about how video conferencing technology will be used to affect such a consultation. The patients will be explained the fact that his or her healthcare information will be shared with other individuals for scheduling and billing purposes. Risks and benefits, including interruptions, unauthorized access, and technical difficulties, will be explained to the patient. They will also be explained that finally they'll be reviewed by the anesthesiologist on the day of surgery. So, how do they conduct a telemedicine pre-anesthetic evaluation? So, what is the setup which is required? So, telemedicine setup. Both the sites are equipped with video conference television, monitors, and cameras that allow live two-way communication. So, the remote patient site. In the patient site, you have a light source which is connected to two analog cameras. The first camera functions as the room camera, and the second serves as the airway camera for the intraoral views. There is a digital electronic stethoscope which permits transmission of heart and lung sounds. The connection which they used was the North Network existing communication network smart system for health provided by Bell Canada operating system with bandwidth of 384 kbps. At the consultant site, there is a monitor, there is a camera, desktop computer, and a digital stethoscope. An anesthesiologist is present at the consultant site, while an attending doctor or nurse can accompany the patient at the remote site. History is taken as per conventional consultation. Examination of the airway, respiratory, and cardiovascular system is performed. Mouth opening and Malampati score assessed using airway camera. Nurse at the remote center is instructed on positioning of the stethoscope on the patient's chest and precordium. Relevant investigations ordered by consultant anesthetist are noted down by the attending doctor and are reviewed by anesthesiologist on the day of the surgery. The second comes its use in pediatric liver transplant. This was also a pilot study which was done where 2 cases of elective living related pediatric liver transplants were performed at Narayana Hridayalaya Institute in Bangalore with pre and intraoperative consultations by physicians at the Children's Hospital of Philadelphia. Equipments used for this include the video camera, video conference device by Polycom, an ISDN line with 128 kbps bandwidth through which voice and data transmitted simultaneously. GoToMeeting online software were used for lectures preoperatively 1 week before the procedure. They had a pre-op lecture. Then during the anesthetic course, they contacted through telemedicine for any advice. Then comes a teletherapeutic drug administration. This was also a pilot study for teletherapeutic propofol infusion. It consists of a computer at the patient site in Munich and a computer at the control site in Erlangen. They both were separated by a distance of 200 kilometers and they were connected via internet through a virtual private network. Median frequency of EEG power spectrum was used to calculate the propofol dose. Telemedicine in chronic pain management. So mobile device-based interventions are used for chronic pain management, which are broadly categorized into patient education, monitoring of symptoms and medication use, delivery of treatment or self-management skills. They used digital biomarkers and virtual reality for this. Data collected from wearable devices or mobile apps can provide objective measures of pain intensity, frequency, and impact on daily activities. Virtual reality uses two-dimensional or three-dimensional technology, allowing patients and providers to access and interact within a virtual world. Off-site critical care patient monitoring. So this comes into picture in ICUs. The doctor in the local ICU connects the patient to the ICU or CCCU specialist center where the expert cardiologist and critical care specialists review the patient condition online and provide expert opinion to local doctor in managing the patient with the best of the clinical practice. Home monitoring can be done with telemedicine. Patients with chronic ailments can have their follow-up consultation with their respective consultants while sitting in their home or workplaces. The patient is given a device that needs to be connected to an ordinary telephone line. And during consultation, this device transmits the EEG and other relevant clinical parameters for analysis. So, what are the limitations of telemedicine? Technical difficulties will be there. So, network issue will be there where they'll not be able to connect properly. There will be inability to perform in-person physical examination. There is chance of inaccurate dosing based on weight-based drugs. Patient and provider perceptions differ from those experienced doing an in-person visit. Conclusion: telemedicine has become more readily accessible and affordable, and its various applications are growing rapidly with promising results. As technology continues to improve, the potential of telemedicine and its role in healthcare will be tremendous. Thank you.
Hello, okay. Yeah, thank you, Naziya, madam. So, yeah. Sir, now our discussion is open, sir.
Yes, chat box questions to be answered first.
Yeah, okay, sir. Just going through the thing. So, the telemedicine, whether referring facilities and the consultant offering options, who is legally responsible? Sir, actually, I have gone through some articles. Anything about
sir, 1 minute, sir.
Sir,
1 minute. The delegates will not have accessibility to the questions, sir. So, you please read the questions and answer one by one, sir. Either you can answer or allow the people. So, first question should be known to the people. So, it is not, they are not accessed.
I will clearly read out the questions.
Yes, sir.
Okay, sir. Naziya. Hello?
Sir, yes, sir.
Hello. Yeah, you are able to see the chat box question?
No, sir, I'm not
chat
able
box,
to see.
There is a question.
No, sir, I'm not able to see the chat box question.
Okay. There is a question. Who is legally responsible in telemedicine? Whether it is a referring facility or consultant offering the option. See, consultant.
Sir, actually, yes. So we are taking an informed consent, sir, from them that there is a risk of the data can be utilized. So we are informing them in prior that the data will be used. Yes, we are informing them with the informed consent we are taking and then only proceeding with it. So for treatment, like the way we are taking an informed consent, so for the telemedicine consultation also we take a consent, sir.
Okay, so I gone through some articles regarding that. What they say, there is a state medical register or an Indian medical register. Though some of the doctors can get. Sir, tell me, sir.
Madam, the question is very clear.
Yes, sir.
Whether who is responsible legally, whether it is the sending facility, that is referring facility, or the expert who is giving consultation over the phone or telemedicine. Question is straight. Who is responsible?
The person who is referring the patient or person who is giving the medication. Opinion. So it's actually what happened, some of the state medical register or Indian medical register has entitled some of the doctor to get register in their council, sir, or a register in the telemedicine options. So that people are have some guidelines. So they will follow that guidelines. According to me, the person who is giving the opinion, he is the held responsible for the anything happens to the patient. If the medicine is given opinion, anything happen legally, he is the because he is the registered, and all can get registered. There will be option. They will give the option to register, and they will follow the some guidelines. So they have to go through the guidelines, and then if anything happens, the opinion is given by the who is the to the telemedicine. He is held responsible for the any type of untoward things or anything happens. He is held responsible according to me, sir. And it is over to you, sir. Your experience, you tell me, sir.
But actually, both are responsible, sir. Both
Okay,
are
very good.
but
Yes, sir.
primary physician is held responsible for everything because the court simply asks why you have asked his opinion. We are not asking for his opinion. You only preferred that he is an expert. So whatever
Yeah.
opinion you are responsible for that. This is just like a respondent D superior. If a nurse commits a mistake, the nursing home owner
Yeah,
is
the doctor
liable. Same way he has
definitely.
obtained
Yeah.
the opinion of the expert.
Yes,
So,
sir.
but he can drag, as you say, if he is a registered person for teleconsultation, then he
Yes,
can
sir.
also be dragged, or else that person will say, I have I have helped the doctor. It is not a,
Yeah, he start
ah,
escaping. Yes, sir. That's right.
it is that way it will go.
Yeah, that's right, sir. But somewhere at his scene, they're telling that for telemedicine, you could register. For example, I have done a telemedicine 15, I think around 8 to 10 years back in Boring Hospital, sir. So we are registered. Anesthesia department is registered, and then in which one or two doctors has been registered. We have to go and answer the questions.
We
They will
are in
give
the
the
gray
opinion.
zone, sir. Slowly it will evolve. The legal system will evolve on its own to address all these issues. This is just
That
I
is,
hope.
it takes some more time. That's right, sir. It has to be slowly get real. So next question is, Naziya, next question. If many agencies are advertising tele-ICU, whether it would be a practically viable. Naziya?
Yes, sir.
Yeah, once again, I will read the question.
Okay, sir.
Many agencies are advertising a tele-ICU, whether it would be a practically viable.
Yes, sir. It will be useful, sir. Practically, it will definitely be useful. During COVID-19, during pandemic, we ourselves have used telemedicine, sir, for taking specialist advice. So it is a better option for tele-ICU.
So, that is right. We are particularly it is a more practical when we are done a COVID
Yes, sir.
19. So we will be able to, because many of people cannot able to go inside because you have to wear a suit and go inside for seeing the patient. So only the people who are inside, they will chat, give the feedings from the patient, that what all the patient parameters and other things with the WhatsApp. Then the same thing will be submitted to the telemedicine to specialist. Particularly, we are doing intensive specialists who are staying in corporate hospitals. We have attachment, and they will discuss with them. And every evening, we are going to highlight that all the cases, and they are giving the better treatment suggestions will be given. That will be mixed with our consultant and their consultant, and we are giving the treatment. That is right. It will be more useful according to us. So that is a more useful. So what do you say, sir?
Yes, sir. Yes, sir. This is just to sensitize the people who are participating in the discussion. You can go to the next question,
Yeah,
sir.
sir. Okay, sir. Okay, sir. So next question is, can you charge for telemedicine as separate entity? What
Sir,
do you say, Naziya, madam?
yes, sir. It will be charged because they are consulting, so it has to be charged, sir. They are taking an expert opinion.
Yeah, that's right. See, nowadays, after that COVID-19, there will be a lot of telecon consultation is started. So most of all departments, not only a single department, most of the departments, like they will take a tele discussion will be done, and that is for the consultation charges will be charged. Here also we can register the some of the doctors. If our doctor, we can tell them the patient, see, we are giving the treatment according to our knowledge and theoretical and a practical knowledge. And if you want one more opinion. We'll take one more opinion with our outside consultants. We are registered that consultant in our ICU or in our hospital. So we can discuss with them. Some people will be demanding, sir, it's okay, operation, now we have to go to operated, it has to be put on ventilator, or what is the problem, sir? So they may say that we need one more opinion. So that time we can take one more consultation with the outside people. When you take a valuable treatment, definitely they give, depending upon their experience, and we are registered that type of doctors only. So then that is a better to charge for them. They will give a sensible treatment will be given by the consultants. So according to me, it can charge for that. Sir, what do you say, sir?
Yes, sir. Once the service is provided, it should be charged. Again, it is sensitizing the people only. See,
Yeah.
service is provided, but in Indian scenario, we have to think on that lines. But it should be, or else even you cannot have a break-even point for your investment.
Yeah, that is right,
You
sir.
have
So
to
usually,
charge.
most of the patients are always say that when we are admitted 3-4 days, no response in ICU, particularly, they're expecting second opinion. So they
Yeah.
always say that, sir, you are all right, always right. 24 over 100% give a guarantee that patient will become fine. So in that situations, we can have one more opinion with the outside consultation, and we can pay for it according to me. Correct, sir? What you say? We'll go to the next question, sir. Yes, sir. Yeah. So can telemedicine is financially viable? Yeah, I think what Naziya, you tell regarding this. Can
Sir?
telemedicine financially viable? So financially you can variable, you can cost it more or less or like that.
Yes, sir.
That's
Depending on the specialty which they take the consultation, so accordingly they will charge. No, sir.
No.
Yeah.
The question is
Yes,
whether
sir.
the telemedicine is practically viable. That is, you
Yes,
say
sir.
so
Definitely.
many
Yes.
cameras.
Yes.
No. You say so many
Okay.
cameras, photo shoot, computer, everything. For that, whether the patient will pay.
Sir, like the way I told that pediatric liver transplantation, all those cases which are like scheduled for surgery, in those cases, it is definitely it'll help. No, sir. So there is no harm in
The question
investing.
is no. The question is not help or anything. It is definitely helpful. What I'm
Yes, sir.
asking, if you build a nursing home, whether it is
Yes, sir.
practically viable, whether you will get patients
No, whatever.
confirmed.
Yeah. Sir is telling like this. See, we will charge 5,000 rupees per day in the ICU. So you take a consultation from outside. So then it will be that you want a cameras has to be photos has to be
Investment
taken,
maybe 10
discussion will
lakhs,
be takes
15
place.
lakhs.
That will 10 lakhs. So you tell that we take a telemedicine consultation for you and it will charge us at 3,000 rupees. Then patient start telling already you told 5,000 rupees per day, then it is extra
Ah,
charges. That's
Yes,
right,
sir.
sir.
It
But
is.
we can see.
it is
It's
again sensitization. It is again
yeah, yeah.
sensitization. So
So
please
now
think on
I
that
am
line.
telling that you can charge extra, sir. Nominally you can't charge everything, so you can put a charges like this. It will be a charge extra. It will take a second opinion. It has a lot of multi-parameters. Cameras has to be put. You take a consultation. You have to pay for the consultant as well as the investment. What we are doing. So I feel you can. Now we started. We can mobilize the patients to get the fees for that also, sir. I feel.
So in remote areas only it is more useful, no, sir. So those people where they want an expert opinion, they can invest in that, sir.
That's right. When a remote people, when their patient doesn't require a shift from the smaller center to higher center, that
Yes, sir.
time they have anxious that maybe treatment may not be a good, and it will be takes a your if you go to the higher center, I'll get a better line.
Transportation charges and all
Yeah,
that when
that
we
can
compare,
be saved.
it
They can
can be
opinion.
saved.
Yeah, when the telemedicine people may say that this patient can be managed there only, you can wait for 2 days. So if it is becomes good, then there will be charges will be reduced. Therefore, the transportation, shifting, and other things will be comes down for them. So it may be a better. I feel that it is in that way it is good. Otherwise, they can say that shift the patient. Patient is very critical, may not be maintained in the smaller center. We'll go to the higher center where the all the facilities are available in the higher center. That more care can be given to the patient. I think that is
Yes,
also
sir.
a good point. Yeah. Sir, anything, sir?
The next question you can go.
Okay, sir. Okay, sir. So, what about the procedure in tele-ICU, telemedicine? Whether primary physician is absolved of this responsibility once telemedicine consultant is given? See, once again, I'll read. What about the procedures in tele-ICU, telemedicine? Whether the primary physician is absolved of this responsibility once telemedicine consultant is given?
That is,
We
if the
Both.
got
telemedicine consultant and the telemedicine consultant says, you please intubate the patient, the primary physician has to intubate.
yeah, sir. Yeah, that's right.
So whether that if he could not intubate or once he is given, you need not intubate, and if the patient dies, whether the
So who
primary
is
physician is absolved, whether he is not legally liable, because the consultant said you need not intubate. So you are
It's
not
an
intubating.
opinion, sir. We can, I mean, we can also uh, take decisions
Yes,
based on,
on your own. That is right.
yes.
Good point.
Yeah. So they can take a decision if they feel that there is any difficult intubations, or it may be a very patient is obese or anything, something. Then they say that, sir, it is very tough to intubate. We can refer the patient, or we'll what to do, give the suggestion like that. You can take an
So
opinion. So
it is
that's
a combined decision. Rather, we can
yes,
say it is a
yeah,
combined decision, combined responsibility. Good.
definitely, sir, definitely, sir, definitely, sir. Okay, sir. So next question is Dr. Madhu Kumar Rajgopalan. That leaking from the EMR. I think this is for the electronics medical record. Asha madam.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Yeah. The question is that Dr. Madhu
Yes,
Kumar Rajgopalan. Data
yes, sir.
leaking from EMR. Data leaking from EMR.
From
How common it is, sir?
sir,
Data leaking.
data leaking is very common, sir, and it is very much escalating. When we got to see the last trends in 2023, in one state only, it was more than 700, and in mid 25, it was more than 500. In US, more than a million, sir. So data leakage is a very escalating problem in EMR, sir.
So what can be, yeah, that is it. Leaking is very common because multiple people are involved in the storing the record. So from the one level to other level, anything can be done to prevent.
Yes, sir. Like when I was speaking to one of my friend regarding this, regarding EMR and all, for example, at Nimhans, at 300 acre of land, they work for for one connectivity solutions. They have taken wireless connection for 300 acre land in at Nimhans. They are completely separate from cyber security people. Cyber security people are very strong there, and they work with electronic health record people. These electronic health record people, they in turn work with medical professionals and technicians at Nimhans. So they have divided their workload, so each one is responsible for their own negligence.
Okay.
Hello,
So there will
am I
be,
audible, sir?
yeah, tell me. Yeah, you are audible. Little disturbance is there, but otherwise it is
Yes, sir.
audible. So their system is working, but it will huge investment.
It's
It is
quite a
huge.
lot, quite a lot of investment, sir. It is a huge investment. But what they
Uh,
said when they divided the system among the four groups: one health professionals, another set of people working on electronic health record, the other set of people on cyber security, the other people maintaining the wireless connectivity. They have improved the data security. That's what they are telling.
can we do the decoding or anything to prevent other things,
Sir?
particularly for decoding of the things? See what happens whenever the it will be MLC case. Particularly, we don't want to keep everything in.
Yes, sir.
So particularly the medical legal cases or anything which is a very like any kind of cases. So some of the things which is a very dangerous or anything, that cases can be do decoding or specializedly that cannot be relieved without the permission of the primary consultant. Can we do like that?
Sir, everywhere there is a problem, sir. Everywhere there is a breach
Yeah,
in
because
security.
multiple people are involved in this.
That can happen. Human error can also come here, and technical error also come here, and there
Yeah.
can be technical leak also, and they build it up in cloud system. From there also they can breach the
Okay.
security, sir. That's
So I will ask sir, your opinion.
Actually, madam is saying so much. She is casually saying 300 acres of land to build a Wi-Fi station. Am I right, madam?
yes, sir. 300
Ah,
acre of land, sir.
see, can you imagine in Bangalore if 300 acres of land is allotted for a
Imagine.
Wi-Fi station, how much it will cost? We should not even
Yes,
think
sir.
these
It's a
are.
humongous, sir.
See, the 300 acres, even that Bangalore, one area will be 300 acres. So you have to allot one Wi-Fi area, then it will encroach the next city. So I think it is not
Yes.
possible. Probably this is just like when the first computer was designed, it was occupying one full room. Now it is occupying one hand. So in that way, that 300 acres of land to shrink to a level of even less
Yeah,
than zero
maybe,
point
sir.
0.5 acres, or else it is very difficult. Anyway, we are in the crossroads now. But what I feel, you please take a consent. Leak is very common because at the
Yes, sir.
staff nurse level, they can take. Anybody can take the record. Even now, they are doing it like that. But take a consent that it can be leaked. Nowadays, our people are not legally challenges for leakage of health records. Same way, like they are not suing us for awareness during anesthesia. In
Yes, sir.
foreign countries, they will sue us for awareness in anesthesia. Same way for leakage of medical records, we are straight away giving to the patient. They are giving it to somebody else. Somebody else brings. So they are not taking it as a privacy. So we are safe.
Mm.
So we are safe. But it is a very 300 acres and all. We cannot delegate to
Very
the
costly,
cyber
sir. That is a
security.
very huge. That is
Not
right.
possible. Not
That's a few,
possible.
but like what we have seen physically, it is maybe 3 acres or something. I
Whatever it
don't
is,
know the Wi-Fi
madam,
connectivity, how it works. We don't
madam,
know, sir.
first thing it will come only in corporate hospitals which are in major cities like Bombay, Delhi, Bangalore. Imagine 3 acres of land in Mumbai. 3 acres of land in Mumbai. Can
It is
you
very.
imagine? Not at all possible, madam. It is not
I
at all
think.
possible.
Correct. I think only MLC, which is very this thing that can do a something like a police people will do, sir. Some of the this thing they will not without a permission of the higher authority, they are not going to give any type of data, sir. Like that we can do for some
See,
MLC case, sir.
I can tell a easy solution. The personal integrity of the people will solve this issue.
Yeah, hundred
Instead of
percent.
investing, the
Yeah,
personal
definitely.
integrity of the
Yeah.
people
Yeah,
will
it is
solve
between
this
the
issue.
surgeon and anesthetist and who are inside the OT. For example, for anesthetist. So you
That's
say
all.
that that's a he tell you give that one that is happened like that, they will go and leak outside. That should be
That
what you say that
oh,
100. There should be understanding between a
was
surgeon and anesthetist, sir, most of the time.
right.
Can be done. Sir, same next question is also same thing. Sir only asked data leaking out of electronic medical record. Read that is easy, sir. Leak will be multiple people are doing the things. Then they
But
if not. Hmm.
It's
I want to
very
ask one
much,
question.
sir. Leak is too much.
Sir
Madam,
is asking one
Madam,
question.
I want to ask
What
one
is, sir?
question, Asha, madam.
Sir?
Actually, you say
Yes, sir.
you have very clearly said, which I
Yes,
said
sir.
some 25 years ago. I said monitors printout I will not take because legally it will be
Yes, sir.
challenging and it will be used as a tool against me. 25 years back, I said. Now you have very clearly said this electronic medical records always it will be interpreted by the court in the patient's favor. You said
100%. 100%.
always it will be done there.
Yes, sir.
So
It's
Yeah.
I
always,
want so
yes, sir. Yes.
I want to
100%, sir.
ask your opinion. I want to ask your opinion. In such a scenario, is it worthwhile to pursue this electronic health record?
Sir, though it is legally very challenging, but when we see the Indian population, the way we are growing, we need electronic health records, sir. At least to maintain for patient safety for 24 bar 7, their health benefits. We need to have electronic health records, but we have to work a long way for that to happen, sir.
That's a problem is here, sir. What happens whenever there is a, you tell that when hot blocks are there, it is a class, when you take a recording of that one, it is not classically what it is given in the book. Most of these lawyers, what they will do, they will take out the book and they'll read the book. So they will
Ah,
come with that preparation. See, it will never be like that. When you take a recording of the things, any case you take a recording, it is always be a slight fluctuation will be there. They will ask, the fluctuation is there, you are according to book, you are not maintained, that's why your negligence will be there, will punishable. See, this is the my actually when we go for the insurance, when we cover with the medical insurance, that people will say that whatever you write, sir, it should be equivalent to what it is given in the book. then only they will ready to fight. They will not ready to fight what I have done there and save the patient, or bad luck, it will we lose the patient. So they say that whatever it is in the book, because most of the lawyer, the reader, they will never take our experience. When we say that, sir, it will be given in like that, but it is not so. When it is when you're doing the thing, you say that atropine is given first, but it is adrenaline should be given. Book has says adrenaline. You are wrong. You are negligent. See, that is the problem is there with our lawyers, sir. What do you say, sir?
Correct. Because the experience is not written in black and white, but the book
100%.
it is written in black and
Yes,
white.
yes.
Right, sir. That is the
Court
evidence.
relies only on records. Court relies only on records.
They say that 120 heart rate suddenly dropped to 20. How it is possible? It is never it is given. You have done something. You are not given something. You have done everything. Still, it is not acted, sir. It is my bad luck and patient bad luck. We lost the patient.
Even we used to say, sir, when the pulse oximeter shows suddenly recording of 0,
Yes,
probably the pulse oximeter probe may be displaced.
Displaced. That will they not.
But the court says it is 0, you have not acted. So there is a problem. You are allowed it to drop to 0.
Yeah, that's right.
That is the reason I used to say, if you rely on electronic health records, we have to attach a printout from the monitor. If you
100%.
attach a printout from the monitor, it will show 0 at one point of time. Whatever
Definitely,
it is.
sir. Continue. But
It
that is
is
also continuous.
very difficult to convince the judge. It is very difficult.
You always be towards the patient rather than towards the doctor, sir.
Then a doctor is to be the judge. Then only you can say something.
Doctor come, yes, exactly right, sir. We do MBBS, do all specialization, then become lawyer, then it will be protected by the doctor faculty. Otherwise, it's a very tough for them, sir, actually. It's for doctors, it is very tough. Sir, no more questions I'm seeing here, sir.
Then you can pass your concluding remarks and close, sir. Then we will propose formal vote of thanks.
Okay, sir. Done, sir. So, anything, Naziya, madam, anything to say?
In court, sir, what I have
Yeah, tell me, Asha. Tell me. Hey, tell me, madam. Your mic system is not good.
no,
Not
sir.
able to hear you.
Regarding the same, in court, always the first cleaver will be attended first.
First,
Now, sir,
tell me. No, tell me.
can you, sir, what I observed in court, the first griever, the first person who approaches the court, they are given, they're a bit biased. Like always, patient comes first there.
It is always like this, madam. When you have a fight, you first go to police station. You will be stand first. If you are only hit the patient or hit the other party. But if you go first, you will be the protected first. So like that, usually the patient will go first. So the judge will protect the patient rather than the doctor. So next time onwards, if anything happens, we'll first go and run and sit in the lawyer's office. So we'll get complaint police and
I don't see any.
It's always been like that.
As I see, like none of the doctors will go to court for any of the problems that's caused.
What else? Patients will see that many a times if you do a fine, everything from the fine, they say that what they say, thank you. They will thank you also, we're less nowadays. So they said you done your job. That's all. If you have any complication happens, you purposefully done it. So that is the two things from the patient. Now the patients have to be, you should get the confidence of the patient, madam, most of the time. That point will be noted. Always the patient will go and give the complaint first. Okay. That is a thing. Then always the police or a lawyer will uphold the patient. Oh yeah, that's right. What he's come. That's why they are come. So doctor has done a mistake. That's why he's not come to us and give a complaint. Like that will be happen. Anything, madam? Anything to say from your record? So what is your conclusion as a electronic medical records? Anything
electronic
to say?
Health record.
Conclusion?
Nothing, sir. I think.
Yeah, that is already you're told in that one. That is enough. Huh? Okay, madam. What about the Naziya, madam? Anything to say? Telemedicine?
The telemedicine, it is in application in anesthesia, still it is evolving, sir. So we have to work on it.
Okay. So what are the advantage and disadvantage? Can you highlight some advantage and disadvantage of your telemedicine?
Sir, advantage.
Yeah.
Sir, advantage is patient, they don't have to travel. the
Yeah, that
cost
is
of
right.
travel will come down, sir.
They will get a good quality of advice from the good consultant, from the senior most consultant or experienced consultant. Okay, so from the peripheries, definitely it will be more useful in the peripheries where they can avoid traveling from one place to other place or shifting the patient to one place to other place, and little faster assess. You can faster assess. You find that sometimes you find that still patient saturation is not improving when you put him on the patient on ventilator. You can have a consultation with one of the chest physicians, say that anything to be done, sir. I have done all these things. So fast assess can be done. Okay, the
Yes, sir.
better documentation can be done. You can have better documentation in telemedicine. You can immediately, he says that these are the things. You note down, wait for 24 hours. If doesn't improve, then go for start this treatment to this patient. So you can document that one and then explain to the patient that his improvement is not there. That's why I have discussed with that in telemedicine. I'll try to do that one. Okay, so then
Yes,
it
sir.
is a better. These all examples will come whenever there is a COVID-19. We have experienced this thing. That telemedicine is a very disadvantage. Some of the
Disadvantage, internet connection is a must, sir.
must.
And
That is right.
in village areas and rural areas,
Yeah,
they will
that is
not
right.
have internet connection, and
Yeah,
those networking systems which they say VSAT and PSTN, ISDN
yeah,
networking and all will be difficult, sir,
yeah,
for
that is
those
right.
people. And literacy rate in India is less, sir. So
Yeah,
we cannot expect
yeah,
like
that is
not
right. Yeah, that's
everyone
right.
can.
Yeah, you'd say there will be most. Some of the patient doesn't know that what is the telemedicine or anything. If you say that we'll going have a discussion with the telemedicine with the higher center from Bangalore or from Bombay or anywhere, then say the what is that we don't know. Like that, they may we don't want when we are going to charge. Why you want to charge? I don't want you do it here only. That is maybe legal implications are there already. We are discussed about the things. That is one of the till it is not come out what exactly a legal implications taken in telemedicine. Okay, so that is a
Yes,
one
sir.
thing, and the technically should be there. Good, as you say that there will be a current should be there, and it will be always the network issues will be there. That should be then. Next, last is the cost. Robust cost
Yes, sir.
will be the little more because we have to give it. These are the two medicine. Okay, so that is a one.
Yes, sir.
So anything to say from your side, Naziya madam?
Nothing,
That's all.
sir. That's it.
Okay.
Yes, sir.
So what anything? Yeah, anything about our PG has discussed about our resident discuss anything to say? CDSS system. So here that is a combination of the both the thing. The absence of it is a very tough as she did. We got now the artificial intelligence has come. So CDSS system can be knowledge-based one. There is a knowledge. We have some, for example, if you have some lung diseases, interstitial lung disease, what has to be done, you know it. That can be fed into your system. That will show everything. So that is not a knowledge-based. One sometimes some of the disease doesn't know. It will be fed so many things. We doesn't know why patient is not diagnosed properly. We keep a differential diagnosis, start treating the things. In that situation, he says that artificial intelligence will take place of the feeding that diagnose. These are the parameters will go to see. So here it is not fixing to the exact particular parameter that artificial intelligence will suggest. That is the known or unknown knowledge based CDSS system can be done. That is the thing I can able to say. So these are the things I can summarize, sir.
Right.
Anything to add, please add, sir.
No, thank you, sir.
Hello,
Thank you very
sir.
much.
Yeah,
Sir, thanks the entire
thank you, sir.
faculty. Dr. Madhu, she has elaborately discussed about EDSS. Even though she is a postgraduate, her presentation was very good, and it was followed by
Yes, sir.
Dr. Asha on electronic health records, which was in detail. She has discussed about the pros and cons. Same way, Dr. Naziya, telemedicine. Even now, what we are conducting is a telemedicine only. It is a teleconference actually. This Zoom meeting also it's
100%, sir. Yes, sir. Yes,
telemedicine.
sir. Yes, sir.
And see again now we know the
Yes, sir.
difficulties. If there is an internet failure, voice will be a problem. Everything is a problem. So we know the pros and cons. And only the doctor, its moderator, Dayanand sir can do this job of moderating these three elite people who are talking about electronic documentation. And I thank all the 4 people because they have delivered this lecture as per my request. They have not selected the topics. What I felt, these are the left out topics, these people have taken it up. So I have to thank them because they obliged my request. They have not selected their area of choice. I requested them, they obliged. So I thank them and I wish everyone a happy new year, a happy 2026 for all of you. And I request Clarinet Rempa to propose the concluding remarks and the closure.
Yes. So thank
Thank
you
you,
so
sir.
much,
Thank you, sir. Thank
everyone.
you. Happy New Year for you also, sir.
Thank you,
So
sir. Happy New Year to you also,
Thank
sir.
you.
Thank you, sir.
Thank you
Thank
so
you,
much,
sir.
everyone, for joining this session.
Thank you,
Planet
Rimpa.
is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone, and
Thank
a happy
you.
new year.
Thank
Thank
you.
you, sir. Thank you, sir. Bye, sir. Bye. Thanks.
Thank you, sir.